Assalamu alaikum warahmatullah. In the coming few weeks, we will have a series of surgical clubs about multiple injuries, and we will see injuries in different organs. So, in this short presentation, we will come through the ABCD approach of a trauma patient, the chronology of survival, and the 5 minutes that save life. So the paradigm of survival is based on three main pillars: the priority, the action, and the teamwork. So for priority, it is first the triaging of patients to see which patients need resuscitation first. So the triage personnel is tagging all the trauma patients who arrive to the trauma center by putting tags with different colors. And those who will having the priority will have the red color. And we have other colors, the yellow, the black, and the green color. So this is a priority will be set first, and it's important to be mentioned that the triage person is not involved in the management. Then we have to take action. Action is taken by the trauma team, and they work together, and different teams in 2 or 3 groups. They go to every trauma patient who is having the red tag, and never let the lack of definitive diagnosis delay the indicated treatment. And teamwork is the third pillar and the most important pillar. They should work simultaneously, prioritize the resuscitation. In the 10 seconds, only simple question can guide you. So you have to ask the patient, what is your name or what happened? يعني a direct question with processing or 3 processing branches, the clear speech, the forceful volume, and the logical response. So you will give this question, and in only 10 seconds, you will see the response. If the speech is clear, that means the airway is patent. If he didn't answer, that means his airway is closed. So you have to open the airway. Forceful voice or volume will indicate that the breathing is intact. And if the response is disturbed and is not logical, that means there is a problem in the disability or the D. So failure to respond normally is mandate immediate entry into the ABCD algorithm. And it's important also to be noted that in the last edition of the ATLS manual, the 11th edition, an X was added before the ABCD. So what is X? It is exsanguinating hemorrhage, the massive hemorrhage, which will endanger life. So what is added here? The rule is rapid control of massive bleeding by is having a top priority by you stop bleeding by either direct pressure or applying a tamponade or a pelvic binder if there is a massive bleeding from pelvic fracture. So remember the xABCDE. So first airway, like the question we asked before, the patient, you ask him, what's your name? He didn't answer. That means his airway is closed. You identify obstruction first. You have to sweep by your hand. You open the mouth. You look for facial fractures. Do suction if you listen to a gurgling sound from the patient. And then you have the airway opening maneuvers that we will see in the practical labs, the chin lift, the jaw thrust, or the definitive drug-assisted intubation. If the Glasgow Coma score especially is below 8, we need to intubate the patient. And mandatory resuscitation, mechanical protection, cervical spine have to be saved or fixed while opening the airway, because airway opening maneuvers themselves can injure the spine by doing or if it was done vigorously. Then breathing. And breathing, we have to state the most important and the most common, which is tension pneumothorax. However, there are other rapidly lethal injuries. We will mention them. But tension pneumothorax need immediate detection by finding the patient is not able to complete a sentence, the side of the chest is elevated and it is moving less. When you percuss, you find a hyperresonant sound, and we find the trachea also deviated to the other side. So in this situation, you have to immediately insert a needle in the second intercostal space mid-clavicular line until you hear the hiss sound, and within half an hour, the patient should be prepared for chest drainage. And there are other rapidly lethal chest injuries that we have to take care for, which is the open chest wound or the sucking chest wound, the massive hemothorax, and the cardiac tamponade, and the flail chest. And the fifth one actually is airway obstruction. It is included here because we have lower airway passages, which can be occluded also as upper airway, which is managed by airway opening maneuvers. So in few seconds, a minute, you ask yourself what is the patient having. For example, if there is an open wound, you have to seal it. You keep one corner open, or there is a paradoxical movement. It means a flail segment. So we have to have a clear pathway to diagnose, as we mentioned initially. Diagnosis of lethal injuries first is the most important to save life. Then you go to circulation, whether the patient is mentally is stable, alert, or he's anxious, unresponsive, and the pulse and the skin perfusion. So this is the diagnostic triad of shock or massive hemorrhage or hemorrhagic shock, the mental status, the pulse, and the skin perfusion. In disability or neurological evaluation, the Glasgow Coma score of the patient, we have to calculate and we have to remember the components of the Glasgow Coma score, which is the verbal, the motor, and the eye movement. Then the pupillary response is very important to assess the pupils for size, symmetry, and reactivity. And so GCS plus pupil response equals the baseline neurologic status of the patient. And the last is exposure, and completely undress the patient by cutting, and then log roll the patient. 4 persons are needed to log roll the patient to examine the back and protect from aggressive hypothermia by covering the patient and apply warm blanket. So we conclude in the golden hour and the platinum 10 minutes. Remember the xABCDE and continuous reevaluation of the patient until you deliver the patient to a definitive care. And the standard systemic prioritized reproducible approach save life when seconds matter. So I will conclude by putting this an open question. We will answer in the next presentation, first presentation. If a trauma patient arrive with hypotension and decreased breath sounds on one side, which step of the xABCDE approach identifies the life-threatening problem? For more details, we are giving trauma course for candidates since 2004. Up to now, we trained more than 2,000 candidates, and we have a local course called Imbabi Severe Trauma and Extraction course. And also the standard ATLS program was recently also established in Sudan. And hope we see you in the coming lectures, and we'll see you in our courses. Thank you very much.